Hey everybody, welcome to It Is Time to Understand Your Hormones, ladies. I'm so glad that you are here with us, and I'm super excited today because I have as my guest this really incredible woman that I just learned about a few months ago named Dr. Anna Garrett, and she is really teaching about something that I don't think is talked about enough in our culture. Even though we're starting to talk more about hormones in general, and there's some good experts out there, nobody's really talking about the big shift and change in our life, which is perimenopause followed by menopause. And I'm just at that age where I'm hitting perimenopause, so obviously it's up for me in a big way. But I was very excited because I had learned that she was coming out with this book that I actually have here. It's a really amazing book, and it's called. Oh, good. We're both ready with the book. It's called Perimenopause: The Savvy Sister's Guide to Hormone Harmony, and I really highly recommend it. Really, honestly, starting maybe even your mid-30s to do some like prep, and so many women are starting to see issues at that time of their life anyway. And so I'm like, get ahead of the game, ladies. Seriously, like it's really helpful. So just a little bit about Anna and Dr. Garrett. I was like, can I call you Anna? Is that okay?
Yes, please.
You're like, yes, I'd rather. So she's actually a clinical pharmacist for over 20 years, which is one of the things that that drew me to her so much, because I think we need this combination of, the sort of Western medicine tradition and understanding that alongside what a lot of people consider alternative approaches or integrative approaches. And so she started working with women around midlife issues when that became your passion, right? At some point, right. Which I totally want to hear about that. And she actually went to my alma mater for her Doctor of Pharmacy. She went to Chapel Hill. And then she's also certified as an intrinsic coach, which I want to hear more about, and has studied through the American Academy of Anti-Aging Medicine. So she's kind of got the whole package when it comes to all of this important stuff and sort of understanding and bridging these two worlds. So super excited that she's here with us today. Now I'm gonna turn it over to you. Welcome.
Thank you. I'm very happy to be here.
Sweet. So yeah, first I'd love to know sort of, that time that you decided okay, what I'm doing in the pharmacy work maybe isn't fulfilling everything, and what sort of shifted you into helping women in midlife.
Well, I was one, or I still am actually, so we can start there. And then when I worked at Mission Hospital, our local hospital here, I was a manager, and I as part of our wellness program at that point, after I finished my intrinsic coaching certification, they added health coaching as a benefit for the employees.
Oh, cool.
And so one other person and I basically took on all those people, and I seemed to get all the women who would come into my office and say, I'm 49, I'm about to turn 50, and all these things are going on. And I was like, I don't know about that. And I had one person in particular who came in, and this is the thing that kind of really got me going. She had been admitted to the psychiatric ward admission twice. As she puts it, once on the good side and once on the bad side. So on the good side, you admit yourself. On the bad side, you try to commit suicide. And that's what gets you there. But she had been put on all these psychiatric meds, and she said, I knew it was not a psychiatric issue. Something was just not right. And so this is before I'd even started my business. She went and got some hormone testing somewhere in South Carolina. And what it showed was that her hormones were just all out of whack. And so she got that straightened out, and lo and behold, didn't need the psychiatric meds anymore. So that really got me thinking about, okay, I knew I wanted to start a business. I have this pharmacist training. I was just going to do life coaching for women in midlife. But I was like, I went to pharmacy school for 6 years. I don't want to give that up. That would be stupid. So how can I combine those two things? And so I have a friend who is a compounding pharmacist in Durham, North Carolina, and she was doing hormone consultations. And so I said, can I come spend the day with you? And so I did that. And when I left, I knew that was the combination, and that was the missing link. And Dr. Anna Garrett was born.
That's so cool.
Yeah.
And I mean, that just brings up for me, I mean, all of our lives, I feel like there's such a push towards like there's something chemically wrong with you,
Mm-hmm.
And I mean, we're finding out more and more hormonally from
Right.
teenage years on, I mean, can cause all of these different things that we've classified as essentially people being insane or having mental illness,
Right.
And
Exactly.
so,
And I mean, even now, antidepressants are sort of the go-to for anxiety and insomnia, and pick something.
absolutely.
Antidepressants and birth control pills, and those are band-aids. I mean, yeah, they work, but it doesn't solve the underlying problem.
Right, right. And of course, we're seeing so much coming out now about birth control and its
Yes.
long-term impacts, right? And
Yes.
I mean, we kind of had an idea, but now the science is finally backing that up. And you're just
Exactly. And I go, ooh, how many years did I take
right,
those?
right. I mean, how many women actually did not take birth control ever, And they're saying like, because I stopped, I think, taking the pill when I was about 23 or 24,
Mhm.
but they say it can impact you like
Yeah.
20 years after,
Yeah.
So here we are,
Absolutely.
perimenopause. So did you actually start going through some of the symptoms of perimenopause too, to where that
Yeah.
added to your wanting to help women around this?
Yes. I mean, my personal journey has not been all that dramatic compared to some of the women that are in my group on Facebook, because they're dramatic. But insomnia has been my personal little piece of hormone hell, as I like to call it. And now it's the night sweats, and it's just like, okay. And I just I keep tweaking things around. I mean, it's not a static situation, because as we age, our hormones continue to change. And so people, will ask me, well, if I do testing, when am I going to have to do it again? I'm like, well, I don't know.
Yeah.
When something changes, or if you're not feeling the way you want to feel. So it's not it's a moving target for the rest of your life, pretty much. Because some women, even well into menopause, still have issues that come up.
I'm so glad you brought that up, because I think, so many of us are still in that mindset of like, even if we go to a holistic practitioner or an integrative practitioner, we still kind of want that, like that pill and that answer, and that it's
Uh-huh.
going to be this amount of time, and it's like hormones don't work that way. You really,
No.
so much of it is just trial and error and figuring out, what is working for your body. Because even with hormone testing, which I think is hugely important, but even with that, you still have to,
Right.
navigate all of this different stuff. And so I know it can be hard for for people sometimes when they come in and they're just like, but what? You don't know the actual answer yet? And it's like, no, we got to figure it out.
Well, and step one in my work with my clients is always lifestyle, because
Mhm.
if you're not addressing the lifestyle issues, there's no supplement in the world that's going to outrun a crappy lifestyle, or a huge stress level. Because my personal opinion is that stress underlies 80% of hormone imbalances, because cortisol just wreaks havoc on everybody.
Absolutely. And I'm glad, you talked about that in the book a lot.
Mm-hmm.
And it's so funny, because it's something that I've always known, but I feel like just since what I've gone through and the recognition of my adrenal dysregulation before
Mm-hmm.
fibroid growth, like it makes perfect sense to me now. And a lot of women, we just keep pushing through, right?
Right.
Like,
Exactly.
we're like, okay, well, we'll get to that point. And really, like you said, there's no supplement. There's not even foods that will get you to
Right.
where you need to go if you don't change your lifestyle.
Exactly.
So what are some of the things that you recommend to women that they do first off?
Well, sleep. And then the next thing somebody will say to me is, well, if I could sleep, I would. And I'm like, yes, I understand that, but at least give yourself the container of time to try to get sleep.
Mhm.
I think cutting out sugar is huge, and limiting processed foods. And, I've had clients where I said, try not drinking alcohol and see what happens. And it totally fixes everything that's going on. So there's a lot of things that are really low hanging fruit. And unfortunately, drinking of wine tends to be a go-to strategy for a lot of women. So nobody wants to hear that.
Yep.
But it makes a big difference, especially when it comes to night sweats and interrupted sleep.
Right. Yeah, and it's so interesting because a lot of women are on that cycle of, they need wine to calm down at night. They need coffee to get up in the morning.
Right.
Right? And it's totally wrecking your adrenals on both ends.
Yes.
And so I know that's with my clients, that's always the hardest thing to ease back that nighttime, beverage to calm things down.
Well, and I try to approach it with people as, let's just do this as an experiment. You don't have to get married to it. Just try it for a week and just notice what happens.
Yeah.
And that usually is an easier sell than you can't ever drink alcohol again. So,
and that's where coaching comes in, right? You're like,
exactly.
So what are some of the first signs of perimenopause that women should be looking out for?
Some of the big ones are anxiety that's new, insomnia, weight gain that just kind of steadily comes on. Fatigue is a big one. Mood swings. So it's just, and so many of them look like other things,
right.
So if you go to your doctor and you say, gosh, I'm feeling really anxious, their first thought is not going to be perimenopause. It's going to be, oh, here, let me give you a benzodiazepine. A little Xanax for everyone. So those are some of the really common ones. Period changes, so longer, shorter, heavier, lighter, anything is fair game in perimenopause when it comes to periods. And that's one of the things that really alarms people is when their period starts to change, because what I want people to understand is, yeah, you may have been a 28-day girl all along, but there's no on-off switch for periods in menopause. You don't just reach a magic day and, suddenly they stop. You go through this whole evolution of the hormonal changes. So I went through I don't know how long it was several months where I was having 2 a month, and I was like, wow, I don't like that.
This isn't supposed to happen.
No, I was like, no. And then I'd go like 6 months with nothing and then have another one. And so I actually just officially entered menopause this past February. And I'm 59. So I'm an outlier. So people don't think that it's going to take till you're 59. The average age is 51. So I'm on the far end of the spectrum. But what that also points out is if the average is 51, then there's a whole other end of the spectrum that are hitting menopause at like 43 or 44. Right. So it's, that average is the combination of those two ends of the spectrum. So a lot of women will get dismissed when they go to their doctor as, you're too young to be in perimenopause. And I say that is BS, because things can start to change in your mid to late 30s.
Wow. So do you feel like you're seeing more of it happening earlier, or it's just kind of a wide range?
It's kind of all over the map with my clients. Okay. I don't have many that are young, like 35-ish, but I've got a fairly good number that are like 42 to 45. And those are the ones who didn't settle for, you're too young. They were like, I'm getting on top of this. And I think that's really important for, your viewers to understand is getting on top of it and making the changes that you need to make before the doo-doo really hits the fan, will serve you very well.
Absolutely. So what are some of the first things you recommend for women to do to help support their bodies?
Well, definitely looking at dietary issues, making sure that you're eating as much clean, healthy food as you can, making sure that you're eating enough calories, limiting alcohol, working on stress management. I mean, those are all really excellent first steps as far as building a foundation. And then, supplements come in. So for instance, I'm a big fan of magnesium because our soil has become so depleted that a lot of people don't get enough magnesium, and it is excellent for sleep. Yeah. So it's been.
Is there, I think it comes up a lot that people are like, well, how much magnesium should I take? Is there kind of a good place to start?
Well, so let's talk first about the forms of magnesium that are best, because they get into the brain. So You want to stay away from magnesium oxide and magnesium citrate because they tend to cause GI upset in the biggest number of people, and we don't want that. So diarrhea is very common with magnesium oxide,
Right.
and it's not well absorbed.
Right.
So my favorites are magnesium glycinate, magnesium threonate, and magnesium taurate. My personal go-to has always been glycinate because that's just kind of what I started with. But I've recently switched over to taurate because the taurate turns into taurine, which then helps create GABA in your brain, and GABA is calming. So I've switched to that one. My daughter started taking it too, and she texted me last week, and she was like, "I slept till 8:30 on Saturday morning," and I was like, "Oh."
That's good to know because I use glycinate, and so I didn't know that.
I mean, either one of those is actually fine.
But I like that especially for some clients that really struggle with sleep.
Yeah. And so what you're looking for is, starting with, just to see how you react to it, maybe 125 milligrams of elemental magnesium, which for most products is 1 capsule. And then, I have gone as high as 3. Usually I take 2. So it really depends on your individual response.
Right. Gotcha. It's really tough to get people off of Calm a lot of times.
Yeah.
That's kind of the well-known one,
Yeah.
And I try and tell them, well, it's not, even though, especially people with constipation, they can like it.
Yes.
Like, it's not actually, it's kind of rough on your stomach, even though it's making you go, So,
right.
Let's figure out what else is going on there.
Well, and from a testing standpoint, I think it's important to understand that a serum magnesium level is not going to tell you anything about your magnesium status. It needs to be a red blood cell magnesium level. So, and most doctors.
There was a good way to test your magnesium level.
Yeah.
Cool. Okay.
Yeah.
Let's talk a little bit about testing. So, what do you tend to, when a woman comes to you, what do you tend to do first in terms of testing?
I tend to use the Dutch test with most of my clients, unless they're on hormone supplementation already. And then if they're on like topical progesterone, there's the only good way to follow that is to do a blood spot test. So that can be obtained from ZRT Lab, and basically you stick your finger and get a drop of blood and send it to the lab. And the reason that's the best way is because it's capillary blood. So it'll reflect what's going on in your tissues better than any of the other methods. So like with serum testing of progesterone, if you're using it topically, it won't show up on a blood test at all. But your doctor, not knowing that, will go, "Oh, it's not working," or increase your dose and potentially overdose you on progesterone. Checking it by urine is not a good way to do it either. And saliva, if you try to check a saliva test of somebody who's on topical progesterone, the value is going to be sky high and it's not going to tell you anything.
That's so interesting.
But it freaks your patients out.
Yeah, exactly, right? Because a lot of people don't know that. And for those that don't know, the Dutch test is actually a dried urine test.
Right, so it's very easy to do.
Right, and on the whole, it shows the other hormones.
Yes, it shows all of the sex hormones, so estradiol, progesterone, testosterone, DHEA, so it gives you the absolute values of those. But it also looks at the metabolic pathways that those hormones travel. So we can see, for instance, with estrogen, your body actually makes 3 kinds of estrogen, which is then metabolized and eliminated from your body. And one of those metabolites is associated with DNA damage and potential cancer risks. So if you have too much of a percentage of that, there are things we can do to manipulate that pathway so that it goes into the safer avenue. We can also look at it and say, your body favors, a certain pathway for testosterone. And if it does, then that increases the likelihood that you might have acne or oily skin, or that you have side effects from testosterone. So it gives us organic acids for B vitamins and neurotransmitters and melatonin levels. I mean, there's just all kinds of stuff.
Right. You really get the comprehensive picture of what's going on.
And then a really deep dive into cortisol.
Right, right. Well, and just going back for a second to the estrogen, I've definitely been reading a lot lately because DIM is something that,
Mm-hmm.
a lot of people just say, if you have too much estrogen, just take DIM, but it turns out that it's not good for everybody, depending on which pathway the estrogen goes down, right?
Right.
Yeah.
Right. So it is, it's especially not good for people that have low estrogen because you're just going to make yourself worse,
Right.
and exacerbate your symptoms. But, if you don't have a phase 1 defect, I know I'm going to, get into a little more biochemistry here
That's
then.
some of the people will appreciate that. So, yeah.
So there's phase 1 and phase 2 metabolism in your liver. And phase 1 is where the 2-hydroxy metabolites made the 4-hydroxy and the 16-hydroxy. And what we want is most of your estrogen going down the 2-hydroxy pathway. And so DIM can push estrogen from 4 and 16 into 2. And then you have phase 2 metabolism, which is where your catechol-O-methyltransferase enzyme comes in. And part of that's genetic, but that pathway can be supported with calcium D-glucarate. So a lot of times, or P5P, which is a form of a B vitamin, but a lot of times you'll see calcium D-glucarate and DIM in the same product, and that's what I actually take. But not everybody needs that. So it's important to be able to look at that pathway. If you're already sending 85% of your estrogen down the 2-hydroxy pathway, you don't need them.
Right.
I use it. My estrogen levels are actually low, but I use it because when I started taking testosterone, it was converting to estrogen, and it caused me to have another period. And I was like, oh, no, 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 no. So the DIM will block that conversion.
Gotcha. Okay. So there's so many levels of sort of understanding.
Exactly.
Yeah. What do you think about liposomal glutathione for phase 2? Is that
I like that as well.
Yeah. Okay. Because, one of the things, that I try and work with my clients on that have estrogen dominance symptoms, and I know that wording, some people don't like to say estrogen dominance, but, just for the sake of that's what a lot of people understand, is really kind of working from the colon back.
Right.
You gotta get that colon cleared out first.
Right.
There's a lot of issues for a lot of people.
So this is where lifestyle comes in again, because if you're constipated, you're just going to keep recirculating your estrogen. So making sure that your GI transit time is good, and that you're not allowing things to get backed up and recirculate.
Right. And so would you go sort of phase 2 support before phase 1 support then from that place? Or
I would look at their Dutch results and go, here's where the problem is. Yeah.
Okay. That's very helpful.
Because I'm not a big fan of guessing at what's going on with somebody, because I can be wrong.
Yeah. Well, I mean, that's the thing, is you don't really know until you see the test. That's why, especially when I first learned about Dutch, I was like, what an amazing thing. And you kind of learn how little the blood tests kind of tell us. Especially,
exactly.
Especially, actually, can you talk a little bit about cortisol? Because I don't think a lot of people understand cortisol's connection to the sex hormones.
Oh, Lord. That's a whole nother podcast. So cortisol is one of your stress hormones, and you need cortisol to stay alive. So it's not a bad thing, and in certain amounts, it helps you get stuff done, right? So you meet deadlines, you jump out of the way of the speeding bus, whatever. And so in a perfect world, we release that cortisol when we need it, and it comes back down to a low level when we're not under stress anymore. So like, I use my dog as an example. When the UPS man comes to my door, he gets flooded with cortisol because he wants to eat the UPS man. But as soon as that truck leaves the driveway, he's back over in his bed, and all is right with the world. And there's a good book called Why Zebras Don't Get Ulcers that talks about the cortisol response and that kind of stuff. But anyway, the way we live our lives right now, we may not feel like we're stressed, but we do things that keep our bodies under chronic cortisol pressure. So like even being in air conditioning with that lack of up and down of temperatures can be stressful to our bodies, because our bodies weren't made for that.
I've never heard that before. That
right.
makes total sense, but yeah.
Right. So we're chronically stressed. Lack of sleep makes us chronically stressed. Finances, relationships, skipping meals, that causes a cortisol spike. So what we want to do is make sure that we're keeping that under control, because cortisol affects blood sugar. So it causes blood sugar to go up, which means more insulin is released. And the more insulin keeps being released, the more likely you are to get insulin resistance because your cells stop responding to it. Cortisol can block progesterone receptors. So it's tied into, I mean, if you were to look at the way the hormone cascade is produced, you would see that cortisol kind of is there at the top. And it actually, if you want to use progesterone, and your cortisol is low, what is going to happen is your body is going to take that progesterone and basically make cortisol out of it, because it has to have cortisol to stay alive. It does not need any of the other hormones to stay alive, but it's got to have cortisol.
Well, and I know you mentioned in your book that you tend to see more low cortisol with women rather than high, and I think we've been under this impression, right, that like it's been more high issues than low issues. And so how does that work? So when we're under stress all the time, why would our cortisol be low?
So it starts out as high.
Okay.
So when you're first having a stressful event, I mean, I've had clients who just had this whopping cortisol curve all day long. But eventually the HPA axis in your brain gets the message, we've got enough cortisol, and it stops signaling it to be produced, which is when it gets low. The other thing that can happen is your body may keep more of your cortisol that you produced in cortisone form. So cortisone is inactive. And based on your body's stress needs, it's flipping back and forth with cortisol in your saliva glands and your kidneys and some other places in your body all day long. But when your body needs to slow down, your body will sequester it in cortisone. And so that'll make your free cortisol low.
Okay.
And this is where the adrenal fatigue misnomer kind of comes in. You may be making plenty of cortisol, but it may be over here in cortisone where it can't be used to do the job. Gotcha. Another issue that comes up is some people make a lot of cortisol, but it's metabolized immediately. And this is mostly in the case of obesity or insulin resistance or hyperthyroidism. Okay. So these are all things that you can see on the Dutch test as well. So, right. Wow. So whereas if you did just a saliva test for cortisol and it was low, you might label somebody with adrenal fatigue when what they really have is a lot of metabolized cortisol, or they've got a lot of cortisone, and you can't see that on a saliva test.
Interesting. So when going back to using, like, for women that do use bioidentical progesterone, if they're sequestered in the cortisol gets sequestered in the cortisone. When you take that progesterone in, your body is gonna automatically kind of use that as cortisol or shift it to cortisol?
No, not if you have a lot of cortisone, but okay. if you're low on all of your stress hormones, it's going to take that and try to make more cortisol out of it.
Okay. And do you see that happening a lot with women when they first start using bioidentical progesterone?
I personally don't see it a lot because I do the test first, and if somebody's cortisol is really low, we don't go down the progesterone route till we get some adrenal support on board. In my group, however, or other groups that I'm in like, I don't know, I got out of a bunch of them because I just couldn't deal with all of it. But there are a lot of women who are hardcore DIY, let me fix my own hormone kinds of people, and so they'll start progesterone because somebody said it was a good idea, and all of a sudden they're having more heart palpitations and their anxiety level is through the roof and their insomnia is much worse. And that's a tip off that that maybe that's not such a good idea.
Right. And that there's other things that need to be done first.
Exactly.
Yeah. So when you work with women, and so I guess just depending on what you see with the Dutch test, it's kind of clear if they need some bioidentical progesterone
Mm-hmm.
right off the bat or not.
Yeah.
Yeah.
I mean, it has been life altering for a lot of women in a good way. If somebody is on the younger end of the spectrum, I generally recommend that they try Vitex first,
Mm-hmm.
because that helps with progesterone support, and so does vitamin C.
Mm-hmm.
So that, for the younger people that I work with, is usually our first step. But the closer you get to menopause, the less likely Vitex is to work.
Mm.
So, because you're just not producing progesterone, so there's really not a lot to balance out.
There's nothing you can do.
And that's when you go, to the supplementation. And I take oral progesterone. And
Okay. I was going to ask you which form you think is best.
Well, it depends on what you're using it for. So if it's for insomnia, the oral works best, because when oral progesterone goes through your liver, it creates a metabolite called allopregnenolone, and that's what makes you sleepy. If you're using cream, that bypasses the liver, so you don't get that metabolite.
Gotcha. Yeah. Okay. And so pretty much as you are moving into menopause and then are in menopause and postmenopause, do women kind of need to stay on bioidentical progesterone for the most part, or does it just kind of depend on the woman?
It really depends on the woman. Progesterone starts to work less well when your estrogen levels fall out of the ideal range. So, at some point the progesterone may not work as well, or other symptoms may develop that suggest that supplementing with estrogen might be a better way to go. I mean, obviously, if you still have a uterus, you need both.
Mm-hmm.
So, people need to understand that estrogen by itself, I don't think is ever a good idea, but if you've had a hysterectomy, it won't cause you to have uterine cancer.
Right.
That's a whole nother conversation. But, it's just a matter of looking at what symptoms are evolving and what is the best way to address those.
Okay. And in terms of hormone replacement for estrogen,
Mm-hmm.
is that over the counter at all, or is it just a prescription?
Well, believe it or not, there is a biased product that's available over the counter.
Okay.
So
is
it's
that a good product? Yeah. Okay.
I recommend it to people.
Okay. That's awesome to know, because I think a lot of the focus these days is on bioidentical progesterone.
Yeah.
We're sort of not looking at well, as we age, we have to think about the estrogen too.
Well, and I want to be clear that do-it-yourself projects with estrogen are a really bad idea. Just to be very, very clear.
Yeah.
Don't do that at home.
Yeah. Pretty much all of that is, I mean, I get it. I've been there many, many, many times. And especially when you're like, oh, I don't have the money. I don't have the
right.
this. But then you end up spending. I mean, ultimately you spend more on the
exactly.
supplements that you try and the this and the that and piecing together, rather than, working with someone like you and getting to it right off the bat,
Well, and you can make yourself worse.
Yeah.
So
that's the scary part. Yeah. Well, it's interesting, and I had mentioned to you that I was going to ask about this. I'm knee deep in creating this program about fibroids, since I went through what I went through, and kind of the common I'd say like take on it is that if you have fibroids, to help shrink them, one of the things you want to do is kind of higher levels of bioidentical progesterone. And I started coming across some studies that indicate that, fibroids may have receptors that basically the progesterone receptors, and that helps it grow, and so, and really I came across those studies because I heard some women and in some of these groups talk about, well, I actually think it helped it grow instead of shrink. So now, you're in this place of what do you do? And I very much feel like, I don't know what that answer is around fibroids.
And you know what? I don't either. And I looked at some of one of the links that you sent me yesterday, and I think there needs to be, more of a body of evidence we know that estrogen fuels fibroids.
Right.
I think we don't know yet what the role of progesterone is, because some women do really well with it. So, maybe there's a genetic thing where your progesterone, who knows?
Yeah. Well, it's fascinating too, because for me, when I did have the fibroid, which completely threw my cycle off, like I had been a, 28 day or 29 for years. And then all of a sudden I was like 5 days early, and then 5 days early the next month. And it just kept going back. And, I had some, I guess I must have ordered some bioidentical progesterone at that point. I used it at another point in my life that was helpful. And it got my cycle right back to that. So it was very helpful in that. And kind of other, I'd say, aspects, I didn't have any PMS. It was just this horrible bleeding that was happening during my period of fibroid. And then learning that the fibroid had grown kind of a lot in the 3 months between finding out about it and the surgery. So that's really what has made me question, and it's like, wow, well, it's interesting because it was actually doing some good for sure, because it regulated my cycle, but was it also feeding the fibroid? And so that's kind of where hanging out, like trying to figure that kind of stuff out, and there may not be an answer quite yet.
Yeah, I don't know.
Yeah. Well, do you feel like we also just need a lot more research on all of this stuff?
Oh, yeah. Oh, my God. I mean, well, historically, in all drug studies, women get left out.
Yep.
So that's just kind of been the nature of the beast. But I think now that there's starting to be more of an awareness about, somebody said yesterday in my group, perimenopause is a new specialty. And I just was like, no, perimenopause has been going on since women were created.
Right.
But
we've always had it.
I just didn't even go there. I was like, I just can't.
Yeah.
But I think there's more of an awareness now that perimenopause actually is a phase where things just kind of go off the rails, and all we've really been, taught about, if we were taught anything at all, which is probably more the case that people don't get any information. We just think about menopause and hot flashes and that kind of stuff.
Right.
But there's a whole universe of things that come way before that. So I think there's an opportunity for people and women like me and you and that are involved in the reproductive area to really make our voices heard and say, we need to do some actual studies on this, because most of what's out there is anecdotal.
Right. Absolutely. And even simple things like, when it comes to progesterone, they're actually using progestins.
Yes, exactly.
Studies, which, I've talked about, trying to educate people the difference between progestins.
Yes.
And so that's, even looking at that study I sent you, I'm like, well, I don't know if they're actually looking at progesterone.
Because they didn't say, yeah.
So you're like, well, that's not really helpful. But yeah, and going back to what you said, like, I think so many people have thought just like, what is actually perimenopause? They just thought was menopause.
Yeah.
Right? So it is kind of this whole like section that people just didn't, they were like, oh, that's all just menopause. And it's like, no, in some ways I think perimenopause can be tougher.
I totally agree.
Yeah. And so
especially when you're unprepared.
Yes. Exactly.
And that's when I wrote the book, I kind of was writing it as a what to expect when you're expecting perimenopause.
Right.
Layout, so that people could just look, oh, this is happening. Oh, this is why.
Yeah.
Oh, here's what I can do about it, kind of thing.
Well, thank you so much for writing the book, because I've been writing it to people that, to explain all the things can take a while. And I think you did a really good job.
Thanks.
Of getting things out there in a way that people can understand, and, good places to start. But going back to the, DIY thing, I do recommend to people really to work with someone. And so, especially someone like you, who is so knowledgeable on both sides of the spectrum of things. So tell people how they can contact you.
Well, there are a number of ways. So I have a website, obviously. It's drAnnaGarrett.com, or you can email me at info@drAnnaGarrett.com. I'm happy to answer questions that people have, as long as they're not like specific to your medical situation, because if I don't know anything about you, then I don't want to give you advice.
Right.
But if it's a general question about, is, say, Vitex good for blah, 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 I'll answer that kind of stuff.
Okay.
And then I have a quiz on my website that people can access to see what they score as far as what the likelihood of being in perimenopause is.
Nice.
And that's perimenopausequiz.com. And then I have the book, perimenopause.book.com. And if you'd like to read the first chapter for free, you are welcome to do that. And that is drannagaret.com/taste-of-peri.
Okay, great. Well, I'll make sure all of those links go, in the notes so people can just get directly there.
Oh, and then there's my Facebook group, which is the Hormone Harmony Club.
Okay, great. And are you on Instagram too?
Yes, Dr. Anna Garrett.
Okay, great.
I'm in all the places.
All the places. You gotta be these days, right? You're like,
yes, God.
Yeah, totally. Well, I could ask you seriously probably a million more questions, and it would go into my own stuff, which we don't need to. I know people always ask me, personal health questions, and I'm like, legally, I can't really talk to you about this without you being a client,
Exactly.
So try and remind people, but thank you so much for being here with me today. And
I enjoyed it immensely. I'm so glad I got to meet you.
I know, me too. For those that don't know, we're actually both in Asheville, which I think is really, really cool too.
So we shall have tea one day.
Exactly. All right. So everybody check out Dr. Anna Garrett's website and definitely grab that first chapter of her book, because you'll be hooked and want to get it. And you can, get it on Amazon, I'm assuming.
Mm-hmm. Barnes & Noble, Kobo, all
your
the places.
Local bookstore. I got it from our local bookstore, Malaprop, so that's always a good thing to do. So
I know I outsold the Mueller report one week.
Look at you. I hope you got a picture of that.
I did. My neighbor works there,
and
so she took a picture and texted it to me.
You're like, yeah.
I know.
I love it. All right, guys. I will see you next time. Have a great one. Bye.
Bye.